sepsis in viruses and bacteria and COVID doesn't necessarily look different. Sepsis is still sepsis.
We are convinced we've seen many children come to hospital later than they would in more normal times, and in some cases that's been crucial.
This is an illness that disproportionately affects deprived communities. And your first response should be to keep your staff safe. Hello and welcome to our Paediatric Sepsis podcast series, brought to you by the Royal College of Paediatrics and Child Health and the team from the Great North Children's Hospital, with guest speakers from all over the country.
Who are you? And why are you so unprofessional?
Stop it. My name is Emma Lim, and I'm a general paediatric consultant from Newcastle. And I'm working here today with Johnny from MediSense, who's our mixed desk. Are you going to say hello, Johnny?
No, I'm silent. I'm the silent partner in all this.
All right. So we're saying hello from Johnny, who's our silent partner at the mixed desk. And today, I just want to welcome again Mark Peters, Professor at Great Ormond Street Hospital, Paediatric Intensive Care and Researcher at the Institute of Child Health. We're sitting here in Alnmouth. We talked last time about the sepsis guidelines, which have come in 2020, but actually everybody else was talking about something else that came in 2019 and 2020. The COVID-19 pandemic. And it seemed wrong not to address this because I think it's what everybody is talking and thinking about. And I think one of the interesting things is we never know what other people's experiences are. So my experience and your experience was quite different, being in the north and the south of the country. So I'm just really looking forward to hearing about what happened with you.
So Paediatric Intensive Care had a little bit of warning of what was coming, both around the Italian experience. And we were pleasantly surprised by how few children became acutely unwell with COVID, respiratory failure and sepsis. We saw tens of children, and I think we screened somewhere between 50 and 60 suspected, and about a third of them turned out to be proven infection. And they all did okay.
Yeah, I think it's really fascinating. We had that period where we knew what was coming, but it hadn't come. In the Great North Children's Hospital, we went all out. So we moved all our wards around. We completely closed one ward and made a whole new ward ready for all the new COVID cases. And we made another ward where we cleared everybody out for all the adult cases. We completely rewrote our PICU, our Paediatric Intensive Care guidelines, who we would admit, how we would admit them. We put all the doctors on a new rota, and then we just sat and waited, and not much happened.
So we underwent the same reorganisation. We effectively organised a new intensive care unit that was going to be an area where the suspected or proven cases were cared for. So we had to reorganise rotas and flow and all the PPE stuff. And we saw a steady flow of patients. Most didn't have COVID as we recognised it in adults, but quite a number had incidental positive findings for the virus in the context of head injury or seizures or things that were probably unrelated to infection.
What we noticed was that everybody stopped coming, full stop. So the paediatric emergency department was really quiet. Anybody who came in with COVID, especially the younger children, was actually well. And some of them we just picked up on screening. So they didn't even have any symptoms.
Yes, and I think we saw a huge reduction, about a 3/4 reduction in our population of emergency ICU admissions for normal diseases. And in fact, a good proportion of our intensive care staff went and worked in adult services, including I went to UCLH for 6 weeks to work on the adult ICU.
No way.
Which is the first time I've worked somewhere else for 25 years or so.
Must have been a bit of a shock.
It was extraordinary, actually, the scale at which they were working, and the similarity of the patients bed to bed to bed, and that really didn't match the very variable presentations we did see in children.
Yeah, I think that's really interesting. I read about that they all had exactly the same story.
I mean, the most similar thing I can compare it to is a really bad RSV season where our wards might be full of children, infants who are doing time on ventilators waiting for their lungs to heal. The difference being that the length of ventilation in that population would be 5 to 10 to 12 days, and the adult COVID population was 20 to 40 days.
That's a great parallel. I really think you see these children with respiratory syncytial virus, RSV, and you just know. So you know that one's going to need oxygen, that one's going to need non-invasive ventilation, that one's going to go to paediatric intensive care. And you get in the flow of it and you get in the system of it. And everybody changes to recognise that pattern.
And I think the other similarity, at least to the start of the pandemic, was for RSV pneumonitis, there's no disease-modifying drug. I mean, we're talking now in August when we know about steroid and remdesivir and the potential. But certainly at the start, it was very similar. It was a viral pneumonia that would get better with time if you could keep the iatrogenic injury below a certain level.
Everybody worried, but the majority of children didn't even come into hospital. The majority of children who did come to hospital didn't get sick enough to need any specific treatment. Generally, they were observed and sent home in our case.
That's right, yes.
The tiny minority came to paediatric intensive care. So the overall message is this is not a bad disease in children.
Yes, and I don't think we quite understand why children are spared. But obviously that's an important clue to understand for picking apart the pathophysiology of COVID.
The other thing that I noticed is the younger children were really well. So it wasn't usually in paediatrics, we tend to think of the very susceptible, sick children as the neonates and the under 1-year-olds, but actually those weren't the ones who ended up on intensive care. It tended to be the older children and teenagers.
It did, although we did have a couple of very unwell newborns with respiratory failure, pulmonary hypertension. So
there was definitely some concerns about mothers with COVID-19 and their newborn babies.
Yes, and I don't think we understood completely children who were unwell and also had SARS-CoV-2 virus, and those that were sick because of the virus, and the proportion of their critical illness that could be attributed to COVID. So,
Mark, how did you define SARS-CoV-19? And what is SARS? Because, you're just throwing these acronyms around here.
So SARS is severe acute respiratory syndrome.
You've definitely got to keep that in. So we've got to the point where you forgot what SARS-CoV-19 stood for.
Well, SARS was named after the prior coronavirus. Which we never saw.
No. So when you had a small brain freeze there, can you just remind us what SARS-CoV-19 stands for?
So SARS is severe acute respiratory syndrome, which was named after the first of the coronavirus outbreaks 15 years ago.
Yeah.
So.
And I think it's important because I think we'll see other viral pandemics. This isn't going to be the only viral pandemic.
Yes, I'm sure we'll, let's not think about that just now.
What kind of children, during this recent pandemic, what kind of children ended up on your intensive care unit? Was there anything that you could draw from the ones that ended up really sick?
So I think the kind of children that ended up on our ICU during the pandemic kind of fall into three groups. There were those who would have come normally from the kind of diseases that always happen, and there were fewer of those, presumably because children were not at school and not interacting in the same way to share infections. There were children who had diseases that overlapped with the adult presentation of COVID-19, of respiratory failure. And then later on, there were children with rashes, high temperature, and occasionally shock that got grouped into this syndrome called the Paediatric inflammatory multisystem disease that's temporally related to the SARS-CoV-2 virus. It's a clumsy name.
Well done for saying that in one breath.
Yeah, Pimms TS.
Yeah, Pimms is usually something I drink.
So I think the Pimms TS was fascinating. I think it clearly was a separate entity, but the degree of overlap with other causes of fever and rash has not been fully defined. I think it's reassuring that the vast majority of these children did very well. And I was a bit uncomfortable with how there was a rush to give anti-inflammatory treatments to so many of these children when so many of them had done well.
So I think the first point to pull out is sepsis in viruses and bacteria and COVID doesn't necessarily look different. Sepsis is still sepsis.
Yes, but of course we're challenged by the low quality of our definition of sepsis. And if you remember in the last episode, we were discussing that infection that threatens your life is effectively sepsis. And clearly COVID can do that via respiratory failure. It can do it by triggering this systemic inflammatory condition. So by that broad definition, they're all sepsis. That's not how everybody tends to use the word.
No. So I think that's really interesting. Given that, do you think we need to make any changes when we see children with potential COVID and potential sepsis in the front line before they get to you?
I think when you are faced with a child with signs of infection and being seriously ill, the guidance from the Surviving Sepsis Committee, I think, hold true now as much as ever. It may be more difficult to deliver the care, it may be more challenging in the PPE and the limitations on access to hospitals, but actually the principles are the same. You have to have a systematic approach to assessing a child, and you have to consider how their condition is changing with time.
I think it's really interesting with my infectious disease hat on, and I think this is a kind of sea change. When you see children or anybody with potential COVID-19, that is an infectious disease, and your first response should be to keep your staff safe. So my priority is that everybody knows how and when to use PPE, because actually, if all your staff get sick, you're not doing anybody any favors. So one of the things that we practiced, and it was probably the most important thing, was when people ring the emergency buzzer, you do not run in the room. You put on your PPE before you go and see them. And nurses got down to doing it in like 30 or 40 seconds. But those 30 or 40 seconds matter so much for the integrity of your staff and your hospital.
Yeah, I agree. I think properly used PPE was incredibly effective. But there are many challenges to doing it properly.
Yeah, tell me about it. So PPE, or personal protective equipment, Do you know, in this whole pandemic, I think I spent more time teaching people how to put it on properly than any other one thing I did.
It doesn't surprise me.
Yeah, no, my life is really exciting. At the end of our last podcast on updating the guidelines, we were talking about steroids and sepsis. So that is actually a really difficult decision. And I'm really interested in, it seems to be a good treatment for adults, but we have absolutely no evidence on how it should be used in children. What are your thoughts?
Yeah, so the rationale for giving hydrocortisone in resistant shock is it supports the action of vasoactive medication and may resolve shock more quickly. The downside, at least in adult studies, is that it tends to increase the risk of secondary infection. My personal view, and this is a sort of interpretation of the evidence, because the evidence doesn't come down clearly one way or the other, I think children are at lower risk of some of the secondary harms of steroid. They have lower rates of iatrogenic or nosocomial infection because their lengths of stay, both in the ICU and in hospital, tend to be shorter. And they tend to have shock earlier in the clinical course of sepsis. So if you have an effective treatment for shock, which is a bigger part of the problem in children, and you have less of a downside, it probably makes it sensible to use steroids, but only at the point where you're failing to get control by first-line fluid resuscitation, and probably you're on a healthy dose of adrenaline before you're considering it. There are other things that can perhaps improve your targeting of steroid therapy. So if a child does not have evidence of a sort of hyperglycemic stress response, that probably suggests they're a bit undercooked in terms of their innate stress response. It may be reasonable to supplement that. Obviously, anybody who's on regular steroid therapy for some prior disease, and in the rare cases where we see purpuriform nowadays, I would again have a lower threshold for giving supplemental steroid.
Excellent. Are you giving it in physiological doses or?
Yeah, so we would use physiological replacement, 0.5 milligram per kilo of hydrocortisone 6 hourly.
So the question is we have no evidence. Do you think there'll be a trial of steroids in children?
It's happening in the US at the moment.
So watch this space. There will be more information soon. And we're waiting for the second wave. What do you think it's going to be like?
I'm not sure I'm any better placed than most of the population to judge that. I suspect it will be a long but not particularly high peak. I think this will be with us for the next 18 months or so.
As a paediatrician, my main point is that this in children is a minor disease and children need to get back to school, and that not being in school is a really big issue. I think that we are coming up to the winter season, so we've got RSV, respiratory syncytial virus, and flu on its way. So the usual recommendations for that, plus if you are one of these people who should be having a flu vaccine, this is the year to have it.
Yes, I think there's another point we haven't covered, which is the child who comes to hospital with a life-threatening infection is still much more likely to have another disease, group B strep in a newborn, pneumococcal sepsis, perhaps in a older child. They're still much more likely to have it than they are to have COVID, even at the peak. And so whilst all our attention is drawn to the excitement and the constraints of the pandemic, it's really important that we still do what we've always done as well as possible.
So, Mark, I completely agree. Most children are sick from the things that have always made them sick, and coming to hospital is safe. We've done many, many things to make it a safe experience. So if you think your child is unwell, bring them to seek help. Don't sit at home.
Yeah, I think we're convinced. We've seen many children come to hospital later than they would in more normal times, and in some cases that's been crucial.
The jury is out, interestingly, about whether more delayed presentation or not, but my gut feeling was they did. The only other thing that was really amusing is everybody was fine, and then during lockdown they all bought trampolines. Yeah, did you see that? They all bought trampolines in lockdown because you stuck it in your garden, and the incidence of trampoline-related injuries went up by 30%. We have a trampoline. It was gifted to us by the local neurosurgeon. It is the most unsafe trampoline in the world. It has springs with no cover and no safety net, and it's enormous, and it's very old, which makes it super bouncy. So every child comes to our house and jumps on the giant, really unsafe trampoline gifted by the local neurosurgeon. Yeah. I'm sure he won't be listening.
I'm sure all of any of the orthopods listening will be like, is there such a thing as a safe trampoline?
So, Mark, COVID, there's no treatments that we know of, proven treatments in children at the moment. So I feel like our only way forward is research and putting all our efforts into research.
So I think the UK punched hugely above its weight in the pandemic in terms of getting proper interventional trials up and running. I think the recovery trial was an incredible achievement. There's something called REMAP-CAP, which was a community-acquired pneumonia study that was already running, that was repurposed. So a whole collection of studies put into the COVID world very quickly, and recovery in particular included children in recruitment shortly after it started. And I think that was a huge achievement to get to the point where data were being collected systematically. Well, there's no doubt the way forwards through research, and I think that's from a base where the UK was extremely organised through the National Institutes of Health research in getting urgent priority work established and out to many centres. And the recovery trial in particular that led to the dexamethasone breakthrough for adults with COVID also recruited children. I think that's absolutely the way to go. Flexible protocols on platforms that can continue is something we may be a sort of important legacy of the pandemic for critical care research in general.
I think for me, the national approach is really important. So we are really lucky to have a national health research group. We're really lucky to have a national health service. I'm part of the Perform and Diamonds trial, which is EU Horizon funded projects looking for a new molecular diagnosis in febrile children. And we did exactly as you said. We've repurposed. We're collecting samples and data on children with fevers and COVID and no fevers and COVID as we speak. So absolutely vital to get new, quick, reliable tests. The other thing that I think has been really interesting to me, and we were talking about delayed presentation, is about equitable access to healthcare. I work in an incredibly deprived area of the country, and I think that the thing we saw more than anything else is this is an illness that disproportionately affects deprived communities.
Yeah.
And I particularly worried in lockdown and during COVID about how children of parents who are less fortunate accessed healthcare. So, for example, if you don't have food, if you don't have a car, if you live in a place where actually you have no garden and you're living with 2 or 3 generations, this puts you at a disproportionate risk, you and your whole family. And I think there's a huge amount of work in thinking how we support these particular groups throughout paediatrics, from primary care to paediatric intensive care.
I think that, and my experience from the time on the adult ICU was very clearly this is a disease of deprivation. Older males, hypertensive, poorly nourished,
poorly nourished is really, really important, because I think that poorly nourished includes obesity, because the cost of eating healthily is disproportionate, and obesity is strongly related to deprivation. So, Mark, fascinating to talk to you today. It seems to me that the message for young people, children and their families is that they will generally be well during COVID, and that what we can do for them is to keep ourselves safe and absolutely power ahead with any kind of research.
I agree. I mean, I think the things that threaten children during the pandemic are the same things that threaten children outside the pandemic, and we've got to pay the same attention to them.
Trampolines.
Sepsis.
Bad food. Obesity. Not being in school.
Indeed.
I think that this is a fascinating disease. I think that the impact of this disease is far beyond just paediatric intensive care. And I think that this is giving us food for thought in so many different areas. So no pressure, because we've only got 1% left on Mark's computer. So I have to say this very, very briefly. But what we've learned and what we've come through in this pandemic has been an enormous amount of help. It's about research. It's about the facts that we can keep children well. And before this runs out, I'd like to say thank you very much, Mark.
Thank you for having me.
Well, thank you for having me.
This podcast was created by MediSense. You can find more podcasts and other creative learning resources on our website at www.medisense.org.uk.